I'm Lee-Fay Low. I'm on the lands of the Gadigal people of the Eora Nation, and I'd like to pay my respects to elders past, present, and emerging. I'm here today to talk about everyday reablement for people with MCI, and as a bonus, I'm going to talk about principles for promoting brain health because those principles are really important for people with MCI as well. So I'll talk about the brain very briefly, brain health, tell you what mild cognitive impairment or MCI is, talk about reablement with a little r, and then give you some cognitively informed reablement approaches for people with MCI. But first, to start with, so that we're all engaged, tell me in the chat, Marie's going to help me read it, what does our brain do? Tell me about all the functions that we use our brains for.
I mean, I can kick this off. Mine tells me when I need another coffee. Mine says it's getting a little low and it needs a coffee sometimes. So,
Absolutely. Body awareness, very important function of the brain. Back
so
here somewhere is what it does. Yep.
yeah. And so we've got it shapes our personality, it runs our body, helps us to
Yes.
make decisions. Wow, it's going very fast here. Everything from mobility to thinking, all our emotional regulation. So if we don't get coffee, our executive function, uh, helps us plan in planning, coordinates, breathing, blinking, basic functions, creates memories, problem solving, everything about us.
Thanks. Thanks, everyone. Thanks, Marie. So you covered many of the things that the brain does, from coordination down here, vision, reading. I'm pointing at my head if you can see me, hopefully. The frontal lobe, which is responsible for planning, concentration, problem solving. Our memory, kind of like sitting here as well. So our brain is really important for controlling lots of things, which help in our daily function. And depending on which bit of the brain is injured, affects, I guess, where people have more problems relative to other problems. We've started thinking about a life course approach to brain health, which means that we are thinking about how we get brains to develop healthily in preconception and in the early years, and then how we keep the brain healthy as we age. So I'm going to ask you some to guess what age do you think the brain stops growing? And so that's the first question. So put it in the chat. Marie's going to read it. So have a guess. What age do you think the brain stops developing?
So we've got some people who think it doesn't stop developing. Some are saying 20s, 30s, 40s. Some are suggesting it's different for boys, 25 for boys, early 30s. Got a whole lot of people who think it never stops developing.
Right,
So
great.
lots of different answers in there.
Wonderful. So here is a graph. It's very exciting. Graph. Hang on. I'm just going to get my notes up so I can tell you all about this wonderful science. Uh, it is this graph aggregated 123,000 MRI scans. So they collected 100 studies, and from those studies, they amalgamated all these MRI scans from uh, prenatal fetal babies, amazing, to people who are 100 years old. It includes a, yeah, 100, so 100,000 participants basically, and it shows us where the peaks of brain growth are. The peaks are the triangles here. So the peak of brain volumes is in late childhood, but white matter, which is this blue peak here. I don't know if you can see it on you probably can't see my mouse. So you'll just have to look at the light blue line under young adulthood where there's a light blue triangle. That's the peak for white matter volume. And white matter is the connections between the neurons. So unfortunately, our brains do eventually stop growing in size, and the connections between the neurons seem to peak in young adulthood. But that doesn't mean that those connections don't keep forming and neurons keep forming right into middle adulthood, which is where I am, and in late adulthood as well. The other important line on this graph is this gray line, which is really low at the bottom all the way and then just goes up in late adulthood. That's ventricular volume, which are the size of fluid cavities in the middle of the brain. And they get bigger in late life as our brains shrink. So, what we really want to do is avoid our brains shrinking, and we're going to keep our brains healthy as we go through life. This next graph is here we are. So we've been thinking about this life course approach to brain health, and I want you to go in the chat and tell me if I'm hoping that as a group you can identify all 14 modifiable risk factors for dementia. Some are in early childhood, a lot of them are in midlife, and some of them are in late life. Oh, Marie's got a coffee, so she's great. So hopefully you're putting in the chat the risk factors for dementia. Let's see if, as a group, we can get all 14 of them.
So we've got alcohol, smoking,
Yes.
brain
Yes.
injury. So I'm counting three. Got
Yep.
depression, education, going too fast, hearing loss, high blood pressure, concussions, diet, poor cardiovascular health. I've lost count. Genetics, sleep. Obesity, physical inactivity, vision loss, trauma. Head injury, isolation again, exercise, lack of social connection. I feel like they're really good at this, Lee-Fay.
Very good. I'm sure.
Pollution in
Yes.
there too. Yeah.
Excellent. Thank you, chat. So we definitely know less education is a modifiable risk factor in childhood, and then in midlife, these are all the important risk factors. So hearing loss, but if you treat the hearing loss, it reduces that as a risk factor. High LDL cholesterol, depression, a traumatic brain injury, a concussion. I know someone said physical inactivity, diabetes. I don't know, came out in the chat. Smoking, hypertension, obesity, and excessive alcohol. And in later life, social isolation, air pollution, and vision loss. I know someone said sleep. There is controversy around sleep. I believe it's a risk factor. It just hasn't made it onto the as well. Lots of evidence for diet. It's not on the official list because it's very hard to exactly give, the specific dietary advice, Mediterranean diet. But I guess the lesson here is we should all be doing things to im- improve our brain health or reduce our risk of poor brain health. We don't want our brains to shrink. But also think about that if someone has mild cognitive impairment, that if we manage these risk factors, it might help them, like help their brain health or help their brain function. So here it's a lot of 14, a lot to remember. The chat are amazing. They know lots about this. I summarize it into make sure you look after your head and your brain. So wear your helmet. Don't go boxing. Try not to hit your head. Seems pretty basic. The second key principle is use it or lose it. Now, I know that we understand use it or lose it when it comes to muscular health. So if we don't walk all the time, we won't be able to walk. But it's the same for thinking. If you stop doing mentally challenging things, then it becomes harder to use it. If you think of all those neuronal connections in your brain that we're growing through life, the way to grow more white matter, to build more connections, is to keep exercising your brain. Um, with use it or lose it, I don't think that people think about social connection as something that they can lose, but we do forget how to socialize if we don't do it. Just think about how terrible we were after COVID in kind of getting out there and meeting people. And so I think that we also lose our ability to socialize. I mean, not completely, but we get rusty at it if we don't practice that skill. And the final kind of principle is healthy body, healthy brain. So that makes sense. Our heart health, our lung health, our oxygen's all collected to our brain. So we need to keep our body healthy to keep our brain healthy. And I think that's an easier way, I guess, of remembering those 14 risk factors. Um, if you are working with older adults and you want a simple brain health tip sheet, and we have made one which actually says, well, these are the things you should talk to your doctor about, and these are the lifestyle things that you need to think about. It's in very simple language, and we also have them in Chinese, Arabic, and Vietnamese on that website. But we're not here to talk about risk reduction. We're actually here to talk about mild cognitive impairment and how to re-able people with mild cognitive impairment. So, if you think that this blue line is normal aging, and the green line is if we've been trying to do all the risk reduction stuff and we've boosted our line up to optimal aging, and the red line is perhaps someone who's got dementia. Perhaps they started at a lower level, or not necessarily, but they've gone down past this dotted gray line here, which is a threshold for dementia. Then between normal or optimal aging and dementia, there's a period which we sometimes call mild cognitive impairment, because people don't have normal aging one day and then wake up the next day and have dementia. Obviously, it's got to be a period between, normal aging and dementia in which they're declining, but they don't yet have dementia. So clinically, I like to think of normal aging as when people might be slowing down slightly in terms of processing, but they're still being able to function normally, and go about their day-to-day activities. The next um, group of people who we notice are people with subjective cognitive impairment. Those people have these cognitive complaints, but when we test them, even with neuropsychological testing, so quite detailed tests, we can't detect a noticeable change. People with mild cognitive impairment, we can see some changes in memory and thinking with, but they're still functioning okay. So somehow, using compensatory strategies, often they manage to go about their day to day life with function. And people with dementia, by definition, have functional impairment. So recapitulate, MCI or mild cognitive impairment has people with mild cognitive impairment have noticeable decline in memory or other cognitive difficulties, but they have preserved ability to perform normal daily function. And then I put in brackets kinda, because I like, especially with technology these days, I think that someone who can still go about their daily function mostly doesn't nec- um, doesn't mean that they don't need helps with particularly technology. And we sometimes talk, I guess, in clinically around how, like, the um, sorry, let me say that functionally it's much more difficult now because you keep having to learn new skills as you get older. So, for example, um, you can now use your phones to get anywhere. I don't know how anyone goes anywhere, like, without using Google Maps. So people who might have MCI might be able to use their phone and navigate successfully, whereas previously they might really have struggled with that old-fashioned map. So technology can help, I guess, re-able someone. But the opposite is also true. Someone who's been successfully writing checks their whole life now can't, mobile bank, and that gives them functional disability. So, like, whether someone has functional difficulties or not is circumstantial and quite tricky, I think, what we're trying to diagnose, to kind of differentiate between MCI and dementia sometimes. So I talked about normal brain aging, the green line at the top, and we talked about dementia, which is the red bit of the curve, and MCI being this yellow bit in the middle. And what we want to do with people with MCI, and there's quite a lot of studies on this now, is we want people with MCI to not progress to dementia. Now, not everyone with MCI gets dementia. 10 to 15% per year will move on from the orange line to the red line. But 60% stay the same or improve with management, which is really good news. And while we're not here to talk about management of MCI, if you think about all those brain health strategies, they're the things that we really pay attention to: physical health and keeping that person active, um, to try and then get the person to revert to normal cognitive function or keep their MCI stable. So the key principles for supporting someone with MCI are very similar to those brain health principles which I talked about, which is, keep looking after the brain, keep active, and keeping that body healthy as well. Right. Marie already kind of said we should talk about rehabilitation. So I did put the slide in. This is the World Health Organization definition of rehabilitation, which is that rehab is a set of measures that assists individuals who experience or are likely to experience disability to achieve and maintain optimum function in interaction with their environments. And then the question then is, well, what's the difference between rehab and reablement? These are this is how the terms tend to be used in Australia, with uh, more intense intervention being called rehab, kind of in a health-based setting, and restorative care, reable and wellness with less intensity and perhaps less improvement in aged care settings. And there's different definitions around who it's for, who it's by, so which professionals are involved, and for how long. I just want to point out that reablement programs with a kind of capital R have a certain definition in in the academic literature, which is different to little r reablement approaches, which I think is what we're talking about in today's conference, and it's the approach taken in Australia. I'm not going to go through kind of the details of it because they're like subtle changes, except to say that there's less evidence for little r reablement approach in comparison to big R reablement programs, because the big R reablement programs tend to have perhaps more formal structure and perhaps more strong integration of interdisciplinary teams. And you'll hear about some of those approaches, I think, in later in today's programs. I will talk a little bit now about cognitive interventions, which are one component, or sometimes the whole approach for reablement strategy. They're very confusing because they all have the word cognitive in them, but they work quite differently. So, cognitive training is what you would expect. Its aim is to improve performance on specific cognitive domains. It's usually computerized. Here's a brain game here on screen. It's used with people with MCA and mild dementia. It involves the person practicing a specific cognitive task, such as a memory task or uh, a planning task, and it can be done individually or in groups. That's brain training or cognitive training. Uh, there's a reablement program called cognitive rehabilitation, and its aim is to improve specific functional goals in daily life. It's been used for people with MCI and people with moderate to severe dementia. And it's an individualized program where we goal set with the person, and then we work with them and often their carer on individual strategies, including environmental modifications and use of specific techniques. Usually working with the person and the carer in their own home. And there is another cognitive intervention called cognitive stimulation or cognitive stimulation therapy, which is a group program of pleasant, stimulating activities for people with mild to moderate dementia. I would think of it as a group-based activity program where there's games, some reminiscence, some conversation, problem solving, where people are keeping mentally and socially active, and sometimes there's a slight physical component as well. So there's these three different types of cognitive interventions, and they all work quite differently. Um, and from systematic reviews, they all do different things. So cognitive training, brain training, um, if you practice a certain area of cognition, you get better at that area of cognition. So with someone, even with mild cognitive impairment or early dementia, if you get them to practice their planning or their memory, they can improve on that specific task. However, generally, uh, they don't improve on other types of cognition. So if I train my memory, then I don't get better on problem solving. And if I train my memory, it doesn't mean that that person's going to improve in their function, in their daily tasks. Cognitive rehabilitation, which is much more focused on function, instrumental activities of daily life, it improves that daily life. Most people are able to meet their goals, but we then don't improve that person's cognition. And cognitive stimulation, which is that group-based, activity program, there's been many more studies on this, but this, uh, but in cognitive stimulation therapy, it tends to improve global cognition, quality of life, mood, and behavior, particularly if you keep the group going. I wanted to caveat that in most of this research, people with MCI and people with mild dementia are combined. So it's hard for me to kind of pull out the evidence for people with MCI alone, but seems to be relevant anyway for the purposes of this talk. So there's no point me tell you about these interventions unless you can get them in Australia. The programs that we sometimes recommend and that we work with are Brain HQ and CogniFit. They're computer programs that you could suggest to someone with mild cognitive impairment if they wanted to do some brain training, just remembering that it'll just improve that specific bit of cognitive function, but may not affect their day to day abilities to do things. Obviously, you're going to be hearing lots about occupational therapy programs, and we've been training some psychologists on this as well through the ADNET cognitive intervention groups on uh, cognitive uh, reable, cognitive rehabilitation programs, and these are funded through the home care package. COPE is one of those OT related programs. And for cognitive stimulation therapy, there are a few aged care providers programs, and CST Australia, a group, quite active group, very lovely group, offering CST training if I guess any organizations here want to take up CST. CST is a really lovely kind of group program. And so if you're interested in kind of learning more about that, go to CST Australia. They are run training a few times a year in Australia. Uh, you can also refer to the Dementia Australia Thinking Ahead program for MCI. It's a 5-session group combining psychoeducation and cognitive strategies. So, those are some of the programs that are available. But besides referring to programs, I guess you want something, well, all of you here are waiting for something more practical from me. So much theory, Lee-Fay. So, let's do something more practical. I already talked about the brain, and I was hoping that the audience today would start to think about different aspects of the person and their cognitive strengths. And I know that most of us don't have the luxury of a neuropsychological assessment, with a detailed assessment reporting on the person's cognitive strengths in different areas. But I think that as you work with your clients, you can kind of identify things that they're better on and things that they're weaker on. And I'm going to put here the list of things that people with MCI and mild dementia tend to be still reasonably good at that you can build on in your reablement strategies. So crystallized intelligence or learned knowledge from the past, it tends to be still there for people with MCI and mild dementia, and you can use that in planning your activities. For example, crosswords. Sometimes they can do very complicated crosswords because they're um, vocabulary is much better than mine still. But this is a simple crossword. Other learned knowledge, like cooking or other skills as well, are things that you can also um, kind of harness that post crystallized intelligence with. And procedural knowledge, such as skills, are often still really good in people with MCI and dementia, and you should be harnessing those to keep them active. For example, knitting. I put two examples of knitting as well because if you ask someone with MCI to knit a sock with lots and lots of needles with a pattern, perhaps that's too challenging, but certainly a simple scarf would be something very achievable. Prompting people to take notes, they can still read and write, and to use those strategies are probably what we teach most often in our kind of MCI groups. So, for example, if the person is going to choir and really struggling with being able to remember the names of people, then, next choir, take a picture and we write little labels, and then they can look at that picture and remind themselves and train themselves to remember the names of the choir. I mean, that's a simple strategy that you could teach someone so that they can remember names because that's what they're having trouble with. For someone with mild dementia or even moderate dementia, you might make a book with names and pictures to help them remember those people. This is from my kitchen. I don't have someone with dementia in my house, but I do live with an older person, and I have labeled things in my kitchen quite prettily because it was just easier for them to find things. I had a breakthrough, I don't know, a couple of months ago, where I was thinking about how to talk about prospective memory. So we often say, well, people with mild cognitive impairment, they have problems with short-term memory. They can't remember, things that happened 2 days ago. But we less often think about their problems with prospective memory. And that's really the difficulty, that they can't think what's going to happen 2 days from now. They can't, and short term memory for the past and prospective memory for the future, they're kind of related. They're related cognitive functions. So if your person is having trouble remembering like 2 weeks in the past, they are often also having trouble planning 2 weeks in the future. Does that I'm hoping that makes sense. So, short-term memory, it's easy to assess. We know the person's got bad short-term memory. Prospective memory is hard to assess, but I think it's really helpful if we're trying to support someone to keep their appointments and plan their lives, because that's really where people with MCI fall down, like missing appointments and things like that. So here are some examples, I guess, depending on how good that person's prospective memory is, or how well they can think about and imagine their future time. And you'll see that people with dementia in particular can't look ahead or think ahead like a month or a week. It gets shorter and shorter. So people with MCI, sometimes we can prompt them or train them to use their phones for reminders, and that works really well. Sometimes we prompt them to put things in their physical diaries, and that works really well. You might have a monthly planner because that person's prospective memory can work for the whole month. But perhaps when you're getting to someone with dementia, again, this is from my household, I have a weekly planner. You can see I put it right next to the fridge, so where that person will see it. And because my person likes to know where each family member is, we have to put what each person is doing so that they kind of know when people are going to be around and when they're going to be home. Um, I think that the key thing is that if you can figure out what that person's ability to learn new strategies are, and people with MCR can you learn new strategies, then empowering them to use new strategies is probably the most helpful. So, for example, learning to take a photo of where your car is. I know many of us do this, but just remembering to do that as you leave the car is something that lots of people with MCI learn to do. Someone Bobby Redman, bless her heart. I know some of you remember Bobby Everett. Bobby Redman taught me how to use Alexas to prompt people in my household. Using kind of everyday technology to do a reminder, not just of what time you need to leave the house, but Now you need to get ready to leave the house, half an hour before you need to leave the house. I think that being able to learn those strategies, like setting a Alexa reminder, which is quite simple, I think that people can do, I think it is helpful as well. So when you're working with someone with MCI, like think about what their strengths are and then build on those strengths and those abilities and adjust, I guess, your strategies depending on what their cognition is like. And these apply not just to doing everyday things, but if you're trying to do exercise with them or other strategies with them as well. Yeah, well, was like I was showing you this. Yeah, so can you teach them how to use um, Google Maps, for example? Okay. I also thought it would be useful to then talk about scaffolding learning if you are trying to teach someone with MCI a new task. So you need to find a good time to teach them a task. Don't try and teach them how to learn to use the Alexa, which just seems quite simple, like right before you're leaving the house. Like find a good time to do it. Break down the task into its component steps. You need to do that yourself as homework. And then develop written instructions with visual reminders, then demonstrate and practice each step, then practice the sequence, and then get them to do it so that they feel confident they can do it, and then have them practice the task successfully with your support, practice it again a few times, and then, you know, teach them how to develop their own learning programs if they're able to do it. And here's one from my house with the remote control. We wanted to watch iView, and we just had to practice those steps. The final thing I wanted to say is that goal setting with older people is really hard. And I know that we say we have to do SMART goals. Maria, are you going to tell me that I'm running out of time? No, she's not. I've got a few more minutes, don't I, Maria? Yes. Okay. SMART goals. And I know that SMART goals are what we should do to set goals, but we also know that if we ask older persons to set their SMART goals, they look at you like you're asking a really stupid question often. Um, so when you go to someone and you say, I'm going to, and they're looking for help, they think that you're going to come and help them do the task. And then you say, well, this is a reablement approach where we're going to do it with you. And they look at you like, well, this is weird. I don't understand why this is. So I think the first thing is that if you're going to take a reablement approach, you need to explain that approach to older people and their family. And then you really need to have a conversation and work with them around the goal setting because asking older people to set goals doesn't work. So last question for the audience. What questions did you use? Oh yeah, I'm too old for goals. I just want to stay home. Can you bring my husband back? Somehow. Tell me what questions you use when you're working with older people around goal setting.
Someone said goal setting is hard. I would agree.
It is really hard. Really hard. Say to the older person, we're going to set a goal together today. They look at you. They really do, Marie. And they're like, I don't know what you're talking about. I don't want a goal.
So we've had people say they ask what's important to you? What would you
Yep.
like to be able to do?
Yep.
What are you hoping to achieve from
Yep.
this journey? Starting small. And that's really big focus on what matters to them. And do they have anything important coming up, a big event or an occasion, anything they want to maintain or change? A focus on baby steps, so taking it slowly, and things that they might be having difficulty with.
Great, thank you. I think that covers kind of my list as well. What's important to you? I like to ask about people they want to spend time with. What is a good day? What's getting in the way? Is there something that you would like to do again or do more of? But those questions that are in the chat are also great ways of doing it. And I think that you really need to ask these questions and then suggest some goals and kind of take the temperature of how the person and the family member you're working with feels about those goals. So I think it is helpful for the team who are working towards supporting that person to understand the goals. And in some ways, once you've set the goal with the older person, like everyone's working towards that goal, including the family. They're really important as well. Um, yeah, if you have care workers, they often know some of the answers and really are quite helpful, I think, in giving you hints, I guess, about what those goals are. Uh, because teaching about reablement is hard. I'm just plugging forward of dementia, where there's a lot of information specifically, I think, for families around rehab strategies and therapies, including how to get services. So if you don't have time to do lots of education with your families, sending them to forward of dementia kind of gives them some information about kind of a rehab approach. So to close then, when you are developing reablement strategies for people with MCI, and I know you'll be learning much more about different types of reablement strategies today, um, understand the person's cognitive weaknesses, build on their cognitive strengths, and then encourage compensation for cognitive difficulties. And particularly for people with MCI or early dementia, um, help them learn how to learn or teach them new skills and take a team-based approach, continuing to have discussions around what's working, what's not working, and what can be done. And I think I will leave it there, Marie, and take some
Fabulous.
questions.
Question early on around a client of one of our listeners who talks about someone living with primary progressive aphasia where language is the only problem. Would that be considered as MCI? And it looks like the trajectory might be dementia, but is that true?
I mean, if they only have language impairment, then perhaps it could be considered MCI. It's a very kind of wobbly line, I guess, like where the clinician wants to draw the line around functional impairment. Some clinicians tend to take the view that they want to wait. So if they're not sure, they'll say come back in 6 months, but they think it's going to be dementia. Whereas other clinicians are kind of much more confident, I guess, in saying it's dementia, even though the functional impairment's quite mild. So if they have PPA and it's diagnosed as PPA dementia, then it's dementia. And like I said, it's kind of like a a great you don't get dementia straight away, so, I think for the purposes of, supporting the person, it doesn't really matter that much. Is that naughty to say, Marie? Am I allowed to say that?
Doesn't matter whether we call it MCI or dementia, it's how we respond.
Yeah.
We did have a question early on, which I think I know the answer to, but it'd be lovely to have you confirm it. So when you were listing some of those modifiable factors, the risk factors there are a list of things and two of them. And someone said, are those in random order or do I need to do them in order of priority? So I guess are there things that are more important?
Um, Great question. From a population point of view, like some if we modified some of the population, they have a greater impact on reducing the risk of dementia. From a personal point of view, I would suggest if you really want to do that, go to COGD risk, which is a University of New South Wales risk factor, where it goes through all those risk factors plus some others for which there's evidence, and it helps you, I guess, decide which ones you need to personally work on. So like I think the priority is working on the ones where where your risk is higher.
I think that's a really good way to answer that because we know if we're carrying a bit more weight or if we're a bit more sedentary in our lifestyles that they're things we need to focus on. I do think sleep is definitely in there as a menopausal woman and knowing that there is some correlation there between early cognitive changes. Can't Sleep is so underrated. Like we need more sleep. We had a bit of a call out to speech pathologists, Lee-Fay. Thoughts on speech pathologists' role in this space?
Look, I love speeches. The evidence for what speech pathologists can do for people with MCI, PPA, dementia is not great, but that's because the research hasn't been done, as opposed to because it doesn't work. I think that speech pathologists are also very good at understanding cognitive strengths and communication strengths of people with dementia. There is evidence for, PPA, the people with kind of uh, language dominant kind of impairments. But I think that speech pathology probably has a broader role that we haven't really defined as well yet because the research isn't there. Yeah.
Absolutely, and it takes a village. I think as Henry would say, when he talks about this as well, we need all allied health, we need all nursing, we need all of our communities to be dementia aware, dementia friendly, and to reduce the stigma. And that will really make big changes. And I think the message I'm taking away is start early with some of those things that can help me with some of those procedural memories, my perspective, all of those things. I'm going to get myself an Alexa because remembering to take my HRT every day is a nightmare.
But it's so easy. Alexa reminds me to do things all the time now. And Bobby Redmond taught me that. So, you know.
Fantastic. A virtual round of applause for Lee-Fay, everyone. Thank you so much for joining us and sharing your wisdom as a statistic, a rock star statistician. Thank you so much for being with us. I know I've enjoyed what you've shared, and I'm sure our audience have taken away a lot of great ideas for how they support not only their clients, but themselves as well. So thank you.
Thanks, Marie, for reading all those chats.
My pleasure.